Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thanks everyone for taking the time for today's session. The IAS-USA Guidelines were updated. The update was posted online December 1, so just recently. These are pretty expansive guidelines that cover ART and issues with HIV treatment as well as PrEP. And our colleague Dr. Steckler reviewed the PrEP and prevention updates in early December. So if you missed that talk, it's available on our YouTube stream. I'm just going to focus on the treatment updates, the parts she didn't cover. I don't have any conflicts or relationships to disclose. I acknowledge our funders. I'm going to do my best to avoid trade names. And this is where you find the guidelines. These were published in JAMA, so a little different source than the HHS guidelines. These guidelines were led by Raj Gandhi, actually brother of Monica Gandhi, who joined us last week. They come from a very, I would call it a powerhouse family of science and medicine. And these guidelines, for those of you newer to HIV care, I would say these are helpful to get perspective, to get expert input. They sometimes push the envelope a little more, though I found some of the updates this time to be on the more conservative side. I'll talk about that. We tend to use the HHS guidelines, the Department of Health and Human Services guidelines, as our sort of first go-to, but I do think it's helpful to review. And so as I go through these, I'll try to highlight where I see similarities and differences with the HHS guidelines or the OI guidelines or PrEP guidelines, as it becomes relevant. And then what I encourage you to do is just, take a look, absorb, think about what you notice that's different or what's different than what you're doing in your practice, and then there'll be time for questions and discussion at the end. But starting with the basics, when do we start ART? These guidelines, I would say, largely agree with the HHS adult and adolescent treatment guidelines. Start as soon as possible. So as soon as a person is diagnosed, linked to care, as soon as they are ready, as soon as you have coverage and can feasibly get the meds, go ahead and start. So they say as soon as possible after diagnosis, ideally within 7 days of diagnosis, if that's feasible. It is reasonable to start the same day or even your first visit, assuming, again, the patient's ready, you have everything lined up for coverage for the medications and no suspicion for an acute OI. And we'll talk about the OIs or opportunistic infections that would make you think about waiting. Or I guess I'll say that a different way. I guess with an OI, you're generally going to want to start OI treatment first, and we'll talk about the OIs, which you would want to wait even longer and delay initiation of ART. At the time of diagnosis of acute HIV is recommended, if diagnosed during pregnancy, begin immediately. You can see the strength of recommendations there. A reminder that the letter is the strength, and then the numbers that follow are the level of evidence. And then these guidelines have a mention that there are theoretical benefits for treating elite controllers, so individuals who have very low or suppressed viral loads even off ART. The theoretical benefit really has to do with decreased inflammation and CD8 activation and other things, but there's not a lot of long-term clinical data or data for changes to clinical outcomes. So they say treatment is reasonable, but don't give a grade to that recommendation. Moving then to when we would start if a person has an opportunistic infection. So in general, for the majority of opportunistic infections, the initiation of ART should occur within 2 weeks of starting OI treatment. So typically you start OI treatment, make sure the person is tolerating it. Once they are and they're doing okay and they're ready to start ART, you start and you aim for within 2 weeks. So take pneumocystis, for example. That would be a standard protocol for starting ART with pneumocystis. Now there are some OIs for which ART is the cornerstone of therapy, and maybe you're not starting alternate treatment. So things like PML or cryptosporidium or limited KS. But then for certain opportunistic infections, there's a little more to think through with the timing. And I'll go through what these guidelines say and then some differences between these and the OI guidelines. So they give a few scenarios. So TB without evidence of meningitis, they say start ART within 2 weeks of starting TB treatment And they make this call out that especially if the CD4 count is below 50, and there have been multiple randomized clinical trials now that really do show mortality and outcome benefit for starting within 2 weeks, especially if the CD4 count is that low. Now, it's a little different than the OI guidelines, which say, yes, if CD4 is below 50, start within 2 weeks, but if CD4 is above 50, start within 2 to 8 weeks. So the OI guidelines give a little more wiggle room there. I think typically, again, you would start TB treatment, make sure the person's tolerating it, make sure the person's ready to start ART, and then really decide what timing is right for that individual. Within 2 weeks, certainly if the CD4 count is very low, and otherwise you have a little more time. TB with meningitis, these guidelines interestingly say within 2 weeks of starting TB treatment and corticosteroids. Again, the OI guidelines give a little more time and space, and they say for TB meningitis, for which there's not a lot of data, they say within 2 to 8 weeks, but do make a note that if someone's CD4 count is very low, there may be benefit to starting within 2 weeks. There's really only one study that looked at timing with TB meningitis, and with early ART, there wasn't higher mortality like with crypto. There just was no mortality benefit. The mortality in both arms, early or delayed ART, was the same. That trial was done in a more resource-limited setting than the US. It's hard to know how much we can generalize. The ART was more toxic than we would use in the US. And so there wasn't mortality, there wasn't danger, but there wasn't mortality benefit. There were more side effects with early ART in that trial, but again, not the same ART would be using. So hard to know how much to generalize, and we try to individualize these decisions. Now, crypto meningitis, for those of you newer to HIV care, this is the one where I think we really have pause in terms of starting ART early, and where this is the situation where we most likely would wait a bit. Now, interestingly, these guidelines say go ahead and start 2 to 4 weeks after starting antifungal treatment, especially if the person is in a setting where you can monitor them closely, you can do aggressive management of their intracranial pressures. They again make the comment that the data for danger of early ART with cryptomeningitis comes from more resource-limited settings where there was less monitoring, less aggressive management, non-first line cryptotherapy, more toxic ART. Again, the OI guidelines, I would say, are more conservative and really say that often with cryptomeningitis, providers delay 4 to 6 weeks, though they do give a lot of room for individualized decision making, and they do make a lot of comments about all the different factors that go into this. And so again, this is a setting where I think there's a lot to consider. But the take home would be with cryptomeningitis, that is one setting where starting within 2 weeks is not what most providers would do in most situations. For asymptomatic cryptococcal antigenemia, so this is a person with a positive cryptoantigen, no symptoms, and a negative LP, they say go ahead and start immediately. And then these guidelines make a call out that if a person has a new diagnosis of cancer, start ART, prioritize ART, because there is data that people do better with their cancer outcomes with chemotherapy and with other treatments if they are taking ART and have high CD4 counts. So if you're out there working and a person's diagnosed with cancer and you're working with an oncologist who's really worried about ART, side effects, for example, and we've seen this happen, I think there is good reason to argue and push for early ART for these individuals, absolutely with attention to drug interactions. Now, these are the recommended regimens for most people with HIV. Take a look at these for a sec and think about what's different from the HHS guidelines, see if you can pick that out. They largely agree, though there's one thing that's missing here that's in the HHS guidelines. Just to go through these, so they recommend in alphabetical order bictegravir, TAF, FTC, dolutegravir plus 2 NRTIs, and this is a abbreviation you've got to get used to if you look at these guidelines, TXF, XTC. So this is their way of writing TAF or TDF, that's the TXF, with FTC or 3TC, that's the XTC. That comes up a lot in these guidelines and not in others. So those two, I think, are the ones that are going to be prescribed most often for initial therapy. And then there's the dolutegravir 3TC 2-drug combination with the caveats as I've listed there, that in clinical practice, I just don't think is being used that much as initial therapy. I think it's being used more for maintenance. What's not here is dolutegravir abacavir 3TC, which is still in the HHS guidelines. These guidelines comment that the abacavir may increase cardiovascular risk, requires B5701 testing, tends to have more side effects. It's a bigger pill. And I agree, in recent years, I really have not reached for dolutegravir, bacavir 3TC as first-line therapy, really for anyone now that we have these other options. They also make the comment that there's really no efficacy benefit of dolutegravir, abacavir 3TC over dolutegravir 3TC, which I think is an interesting way to look at it. Now, one thing that's happened is the European guidelines have added doravirine to their first-line options. And I was interested to see if this guidelines committee would do the same, and they didn't. I don't know if that will change in the future. There's certainly a lot of interest in doravirine because it appears like it may be more weight and metabolically neutral than the INSTIs. You can see there at the bottom the comment these guidelines make about the integrase inhibitors and TAF and weight, and they really say it should not be affecting our choice of initial therapy. So doravirine did not make it into this list. This is a pretty simplified list of initial options we should be thinking about. Now, if someone has had exposure to PrEP and is diagnosed with HIV, the question becomes, what is the optimal antiretroviral therapy? These guidelines have added these two notes. First, on the top, that if someone acquires HIV while receiving oral PrEP there's the TXF, XTC, so that'd be TAF or TDF with FTC or 3TC, that we should be drawing blood for a genotype, and then it's okay to start dolutegravir or bictegravir with 2-NRTIs. So really one of the first-line regimens. This does agree with the PrEP guidelines. I looked in, if you dig through the provider supplement, that is what they say, that if someone is diagnosed, switch to a 3-drug recommended first-line regimen. I think if someone has PrEP exposure and you're worried about resistance to both drugs, you're worried about a 184V and a 65R, and they have a high viral load, you could consider, or we could debate, adding another medication to that regimen until the viral load comes down and you have the genotype result. But they make the point that even if someone has those resistance mutations, dolutegravir and bictegravir with 2-NRTIs tends to be quite effective. So in most scenarios, that will be plenty. And then like the HHS guidelines, this committee also added this note that if someone has acquired HIV after any prior exposure to cabotegravir, we should be drawing blood for a genotype, including integrase, because cabotegravir is an integrase inhibitor, and then starting a boosted PI with 2-NRTIs while awaiting the genotype result. Or the other option would be to await the genotype and then start an integrase inhibitor. Point being, cabotegravir lasts in the system a very long time. Prior exposure and then acquisition of HIV raises risk of integrase resistance. And so there, the appropriate option is a boosted PI and not an integrase inhibitor until you prove the integrase inhibitors are active. The IAS-USA list of recommended regimens during pregnancy largely agrees with the list from the perinatal guidelines. Like the perinatal guidelines, they have now recommended dolutegravir with TAF FTC as the go-to regimen for pregnant individuals or individuals who want to become pregnant. They comment that dolutegravir plus TDF and an FTC or 3TC is a suitable alternative. And you can see the list of alternative options if dolutegravir is not feasible or tolerated for any reason. And then they have some notes about if individuals are taking bictegravir or doravirine, for which there's very little data, or 2-drug regimens, for which there also is very little data, and become pregnant. Really, it's shared decision-making. It might be reasonable to continue those if they're being tolerated well and viral load suppressed, but given the absence of data, they would recommend monitoring viral load more frequently. And then, like the perinatal guidelines, they recommend avoiding cobicistat. Remember, the cobicistat-boosted options levels decrease too much during pregnancy for them to be reliable. The options during tuberculosis treatment haven't changed that much and largely agree with the OI guidelines. I just want to remind you the clinical point that if someone's receiving rifampin, dolutegravir dosing needs to be doubled, as does raltegravir dosing. Efavirenz at standard dosing tends to be okay. Both guidelines, these and the OI guidelines, make a note that TAF might be okay with rifampin. There's one healthy volunteer study that suggested it's probably okay, but there's really no clinical data. There's really no outcomes data for people with HIV. So most providers would not rely on TAF with rifampin. They make points about a couple of other regimens. I'll just go through this quickly. A couple of regimens that you may be interested in, may see in practice. So again, they emphasize that the boosted PIs are the most reliable if someone has extensive resistance or if they are missing doses. So there's a couple of situations here where they call out boosted darunavir as an option to consider. The doravirine options, they really mention only in the sense that they may be useful for persons who don't tolerate integrase inhibitors. They didn't make any comment about switching for integrase inhibitor associated weight gain, which is coming up in clinical practice. It's being studied. Frankly, I was a little surprised they didn't comment on it. We'll come back to the weight gain issue, and I'll let you know what this group recommends in terms of that. For rilpivirine, they comment may be useful because it is a very small pill size. But remember, and this is a good teaching point, remember that if current viral load is above 100,000 or current CD4 below 200, it should not be used. And then I added the reminder, don't use it if someone's taking a PPI or can't adhere to the meal requirement. And then raltegravir, we don't use a ton, but they do call it out as a potential option, especially because it is relatively well tolerated, doesn't have a lot of drug-drug interactions, is safe in the setting of pregnancy intention, but not used a lot. So for switching antiretroviral therapy, there's some interesting points here. They do emphasize again that bictegravir with TAF-FTC or dolutegravir with TAF or TDF and FTC or 3TC. If someone is virally suppressed, those options tend to do quite well regardless of how many NRTI mutations have accumulated. If someone has a 184V and a K65R, they tend to do well. If someone has, one of those plus a string of TAMs, I think there's not a lot of data, and most of us would add something else. But with that level of resistance, there's are several studies now. If somebody is virally suppressed, those options tend to be fine, and we don't tend to need to add anything else, which was an outstanding question for quite a while. They make these notes about switching to long-acting injectable CAB rilpivirine, which I would say largely agree with the HHS guidelines, not recommended in the setting of viremia outside of a research setting. So there is a clinical trial going on. As Monica Gandhi talked about last week very expertly, there is a lot of interest in this. There is growing data for it. There may be single-arm studies that are looking at this more and more demo projects, so we will learn more. But absent that, really it's not recommended by either guidelines committee outside of a clinical trial. A reminder that IM long-acting CAB rilpivirine does need to be administered by clinic staff, so it requires more resources and more visits than oral ART. With on-time injections, there is still a small risk of treatment failure and resistance, so even if someone adheres to their every 1 month or every 2 month injections, in the trials there was a small risk of treatment failure and resistance. That risk seemed to be slightly higher with every 2 month dosing than every 1 month dosing, and it is probably higher than if someone has excellent adherence to daily oral bictegravir or dolutegravir based therapy. So these are important points, I think, for counseling about the long-acting options. They do recommend checking a proviral genotype before switching to CAB rilpivirine if you don't have their pre-ART genotype, because especially of the possibility of transmitted NNRTI mutations or NRTI polymorphisms that might affect rilpivirine. For virologic failure, I thought this was a nice way to think about things. I thought this was a nice framework. So they again say, like with virologic suppression, if a person has at least one active NRTI, then dolutegravir plus TAF or TDF and another NRTI tend to be fine, and we can likely extrapolate that to bictegravir, TAF, FTC. If there is no active NRTI, so if there is a lot of NRTI resistance and no active NRTI and viremia and a detectable viral load, then they are more conservative, and they suggest either reaching for boosted darunavir with 2 NRTIs, boosted darunavir plus dolutegravir with or without another med. Sometimes we talk about boosted darunavir, dolutegravir, doravirine, a so-called triple D regimen for situations like this. Or they do say that dolutegravir plus 2 NRTIs might be okay, but reaching back to the Dawning study, which we've talked about, there was a 4% risk of emergent dolutegravir resistance when that option was used. If someone has NRTI resistance plus low-level integrase resistance, dolutegravir retains some activity, you have to make it BID, and then you're reaching for 1 or preferably 2 additional active drugs from classes not previously used. So these are salvage drugs we'd be reaching for. We've been talking about these, and we'll talk about them in cases. So I'm not going to go through all of them in detail. And then if someone has, on the other hand, NNRTI resistance, high-level integrase resistance, PI resistance, usually a degree of NRTI resistance, then we're really trying to use those agents, those salvage agents from classes that the person has never taken before, and trying to craft an option as best we can that has at least 2 fully active drugs. And then we're really generally reaching for recycled NRTIs as well. So turning to laboratory monitoring, just a couple points that are a little different in these guidelines than the HHS guidelines. So at time of diagnosis, I think this won't be a surprise, viral load CD4, our standard genotype, looking at reverse transcriptase and protease. They agree with the HHS guidelines that integrase genotype does not need to be routine, but this is the situation here in which a provider should think about adding an integrase genotype at baseline. And then like the OI guidelines, they agree with a blood cryptococcal antigen test for anyone, even if asymptomatic, with a CD4 below 100. For viral load monitoring during ART, I would say they largely agree with the HHS. They say within 6 weeks of starting, and then once suppressed, every 3 months for a year, then every 6 months. I think practically what we generally do is every 4 weeks until suppressed, and then space out. And I think going to every 3 months for a couple of checks, then every 6 months is very reasonable. This is an interesting point, though. For CD4 count, they say every 6 months until above 250 for a year. This is assuming a suppressed viral load, then stop. So a little different than the HHS guidelines, which say once someone's CD4 is above 500 with a suppressed viral load for 2 years, then monitoring becomes optional. So they are doing away with CD4 monitoring even more readily. And then you can see here the recommendations at Virologic Failure. Now, a couple other topics that come up in these guidelines in the last couple minutes. So weight gain and metabolic complications, obviously a very hot topic. No one knows exactly what to do. I think it's interesting to go through their summary and recommendations. So as a reminder, and for those of you who are newer to care, these are, I think, points that come up in clinic and that are controversial in terms of how best to manage them. So weight gain does generally occur within the first year following initiation of any ART. Greater weight gain has been associated with use of an integrase inhibitor as compared to NRTIs or PIs, and to TAF as compared to TDF and other older NRTIs. Weight gain also can occur with a switch of an NRTI or boosted PI regimen to integrase inhibitor with or without TAF. It seems to be more likely for women and for Black or Hispanic individuals for reasons that have not been entirely borne out. The use of efavirenz or TDF seems to be associated with weight suppression, which can complicate interpretation when switching off of those regimens. What we really don't know is the long-term consequences of this. For most individuals, whether starting or switching ART, the weight gain that occurs that's related to the ART tends to plateau after the first 1 to 2 years. It does not tend to continue. And we don't have really clear data yet for long-term cardiometabolic complications. Some retrospective cohort studies have found integrase inhibitors to be associated with incident cardiovascular disease, diabetes, hyperglycemia, hypertension, fatty liver disease. But what to do with that, we don't really know. And here's something that I thought was really interesting. So after summarizing all that data, here's their take on their recommendations on what we should be doing as clinicians. So they say counsel about possible weight gain and complications when initiating or switching, document weight and BMI at baseline in every 6 months, perform a yearly diabetes screen and calculate their cardiovascular risk score, particularly if receiving an integrase inhibitor, because again, those may be associated with a higher risk of incident complications. Recommend lifestyle changes if a person gains greater than 5% body weight. And then they come down and say, until there are data proving benefit, switching ART because of weight gain is not recommended. The underline is mine just because I was surprised they came down so strongly on that. But that is the way that they phrase it in the guidelines. They say, until we know more, it is not recommended. Practically speaking, in clinical practice, I think we've all seen or heard about cases where a person is really struggling psychologically with the weight they've gained or have developed these complications. And really, we are faced with a decision of whether or not to switch. Of course, lifestyle changes are what we always start with, and we always encourage, all the other measures before switching ART, but we certainly come across cases where that is what we end up doing. So for me, this is a really individualized case-by-case discussion and decision-making process. And again, I think we will learn more in the future from some ongoing randomized clinical trials that are looking at switching ART because of this phenomenon. These guidelines have a nice section on HIV and aging, which they expanded in this update. They recommend screening for HIV for older individuals and emphasize that older individuals are often diagnosed late, and often the screening and diagnosis for older individuals occurs when the CD4 count has already dropped. So that is an area in which improvement is needed. Initiation of ART is recommended as soon as possible, and it's the same options for older individuals as for younger individuals, though they do urge a bit more caution with TDF. They make notes about addressing polypharmacy, doing regular med list reviews. They call it pruning medication lists and really emphasize the importance of that, as well as screening for issues with cognition, mobility, frailty, and falls. And we've had some nice talks by our geriatrics colleagues in these meetings about how to do that. They make a point that if someone has impaired cognition and is struggling with that really the most important is aggressive management of comorbidities, not adding more ARVs, not changing ART, and do agree with that. And they make a point that we are seeing more integrated care models that combine the HIV practitioner with the geriatrician and the physiotherapist and the pharmacist to all really work together to help provide the most effective care possible, as well as ARV stewardship models where teams are reviewing ARVs and med lists and looking for polypharmacy, looking for drug-drug interactions. And I hope we see more of those types of setups in the future. And finally, for PEP, for post-exposure prophylaxis, these guidelines have come down and said dolutegravir plus TAF or TDF and an NRTI or bictegravir TAF FTC are what's recommended. Realistically, I think a lot of centers are still using raltegravir up front and then switching to one of these, but it is reasonable to go ahead and start these. They make a call out on post-exposure prophylaxis for bacterial STIs based on 2 studies that were done, and they emphasize that really it should be considered on a case-by-case basis for persons at risk. And then there are a couple sections that I just don't have time to review today, but are interesting and worth looking at, but we've talked about in various ways here on ECHO. That was a lengthy review. Thank you for humoring me with that. I hope it was interesting for everyone, regardless of your level of experience with HIV, and I'll stop there.
Thank you for watching this edition of the Mountain West AETC Project ECHO Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.